So let's give it a couple of minutes for the people to join in because we just got out of the trial mode. It'll take a minute or so, I think.
Sure.
This promises to be a very interesting subject. And like Dr. Dang sent the questions yesterday, we were talking about those, it was, maybe we cover the whole subject in 1 hour if we can.
Dr. Vivek, are you normally called Dr. Vivek or Dr. Raj?
Either. Vivek, Raj, Raj, all sorts of combinations, anything.
Okay.
All right, I shall start the proceedings with your permission, ladies and gentlemen.
Sure.
Ladies and gentlemen, a very warm welcome to our distinguished panelists and attendees for today's JMitra webinar titled Wheat-Related Disorders and Crohn's Colitis/IBD. We at JMitra have a vision of serving mankind through innovation in healthcare, and we are very happy to have partnered with CSI, that's Celiac Society of India, Novivel USA, and Dr. Dang's lab to bring this educational webinar to you. We have an illustrious set of medical and healthcare practitioners joining us today for the panel discussion. Our aim here is to create awareness on the linkage between wheat-related disorders and Crohn's ulcerative colitis/IBD. Before I get into the introduction of the panelists, let me state that this is an educational webinar and the views expressed by the panelists are their own. In the event that you're exhibiting symptoms or require treatment, please reach out to your healthcare provider, since each case will be unique in its own way. Moving forward, our first panelist is Dr. Dom O'Brien, Chief Health Officer of Novivel. He is an internationally recognized, admired, and compassionate speaker focusing on food sensitivities, environmental toxins, and the development of autoimmune diseases. He is the founder of www.thedoctor.com and a visionary behind the Gluten Summit, a grain of truth, bringing together 29 of the world's experts on gluten connection to diseases, disorders, and a wide range of symptoms and ages. He is joined by Dr. Vivek Raj, Principal Director and Head of Department of Gastroenterology and Hepatology at the Max Super Specialty Hospital, New Delhi. Dr. Raj has over 4 decades of medical experience and is an established expert in his field. Our next panelist is Ms. Ishi Khosla, clinical nutritionist and the founder of the Clinical Celiac Society of India. She is a practicing clinical nutritionist, columnist, author, entrepreneur, and researcher, a lady who wears many hats. Passionate about nutrition and a strong believer in the power of foods, she spearheaded the first of its kind, a health food company in India called Whole Foods. As part of her commitment towards public health and community nutrition, Ms. Khosla founded the Celiac Society of India, the first of its kind in India, to spread awareness about gluten-related disorders, India, and abroad. Joining these 3 experts is our moderator for the evening, Dr. Arjun Dang, the Chief Executive Officer of the highly acclaimed Dr. Dang's lab, one of the labs in one of the older labs in India, a 39-year-old lab. It has evolved to be known as one of the highly renowned diagnostic labs in the country, known for its quality as well as patient experience. So I will not take up more time beyond that. I will hand over the forum to Dr. Arjun Dang, our moderator for the evening. Over to you, Doctor.
Thank you. Thank you, Arjun, from one Arjun to another. But super excited to be here and feeling super privileged, and it's a great pleasure to be hosting our stalwarts for the evening again. And we've obviously interacted before with Dr. Tom and also with Ishi ma'am. But today we have Dr. Vivek Raj sir also with us. And all I'll say is that the next 60 minutes is going to be a lot of learning for all of us, including the audience and including me also. So looking forward to making the most of these 60 minutes. And so in the essence of time, I'm quickly going to jump on to our first question. And that is to Dr. Vivek Raj. And sir, just to set the tone for today. And I meet a lot of patients who usually come in and due to the lack of awareness or otherwise, they usually use these acronyms also that are very similar to each other interchangeably. So very often I have to educate them, and that is IBS, irritable bowel syndrome, versus IBD. And for the layman and for the general masses, Could you just set the tone and tell us the basic differences between these two? And also, while diagnosing, obviously, these are extremely different, but just for the lay people to understand broadly, how do you define these and what is the difference?
Right, it's a very important question, I think, and we see both diseases. IBS is one of the commonest things we see in clinical practice, and one has to distinguish it from inflammatory bowel disease. So, inflammatory bowel disease is a group of disorders which includes many different conditions. So, it's again a combination: Crohn's disease, ulcerative colitis, eosinophilic enterocolitis, and microscopic colitis. There are multiple diseases which have all been grouped together as inflammatory bowel disease. The common thread among them is that there is an inflammation, as the name suggests, in different parts of the bowel, whether it is just the small intestine and large intestine, or even in the entire GI tract, like in Crohn's disease. So there can be inflammation, microscopic changes, radiological changes, significant symptoms, pain, diarrhea, blood with stools, and all these have significantly worse outcomes if untreated. Irritable bowel syndrome, on the other hand, is just a syndrome, a collection of symptoms, and mostly diagnosed by establishing the absence of any significant organic disease process. So it's more of a functional disorder where the intestines either move too slowly, move too fast, move in an irregular manner, causing discomfort, pain, diarrhea. But if you investigate these patients, you will find no evidence of active inflammation, ulcerations, disease process. So mostly it is more of a diagnosis of exclusion. We do make a positive diagnosis of irritable bowel syndrome, especially in young patients who are much less likely to have inflammatory diseases. And there are certain criteria we use called Rome criteria, which helps identify some of the positive diagnosis. So they're two completely different. They are as separate as a potato and a apple. You know, they are, yes, they are both fruits of some sort. Potato is not actually, tomato maybe, but they are completely different disorders. And irritable and inflammatory bowel disease is a group of disorders. Again, they're all very different diseases in that group of inflammatory bowel disease. The ones we most commonly talk about is Crohn's disease and ulcerative colitis. Diagnosis depends on multiple clinical presentation, obviously, all the symptomatology taken into account, and then investigations where we sometimes do a colonoscopy or endoscopy, as the case may be, sometimes radiological imaging like CT scans and biopsy and microscopic disease, and also do some blood tests and stool tests to sort of sort these things out separately. And once we have made sure that there is no inflammatory component, then many times we say, okay, this is probably irritable bowel syndrome. So there are two different things. Presenting some symptoms are common, but most symptoms are very different.
Thank you, sir. That is certainly sets the tone for today. Dr. Tom, coming to you. So this question's been coming up time and again, and although we do understand that IBD is an autoimmune disorder and leads to inflammation in the gut, and ulcerative colitis being only in the colon, large colon, versus Crohn's that can be anywhere in the GI tract. But would it be wise to draw similarities with celiac disease or wheat-related disorders? And although IBD probably will have more inflammation, but otherwise, do you see any kind of connection between these two?
There's a great deal of connection. And first, let me say that whether a diagnosis is inflammatory bowel disease, meaning the bowel is inflamed, or ulcerative colitis, meaning there's an itis, a colonitis, an inflammation. The important point to remember is that they are conditions of inflammation. When we have a condition of inflammation, we always have to ask and explore. While we're looking for symptomatic relief, we always have to explore, where is the inflammation coming from? Are there some things in my lifestyle that may be contributing to this inflammation? Are there some foods I am eating that I feel okay when I eat them, but could they be causing the inflammation? And a very common one is gluten or wheat, not just the gluten component, but all of the components of wheat may contribute to the inflammation. I want to give you one example to put it in perspective. They looked at over 300,000 people that were diagnosed with inflammatory bowel diseases. And this is in Sweden, where they have socialized medicine, so they have records on everybody. And if they had been sent for examination, endoscopy, biopsy, if they received a diagnosis of an inflammatory bowel disease and they grouped together Crohn's and ulcerative colitis, they looked at the people that had that diagnosis and they followed them for 30 years. They followed 350,000 people for 30 years, 25 to 30 years. And we know with different diseases that our lifespan may be compromised. It's called a standard mortality ratio. It means if you have this disease, the chances are you may pass at an earlier age than someone that doesn't have that disease. With celiac, we know it's 2 to 1. If you're diagnosed with celiac disease and you go on a gluten-free diet, you're still twice as likely to die earlier than someone who is not diagnosed with celiac disease. So we know that that's the case, and that's why the Celiac Society of India was founded, is to help educate people on how to live a gluten-free lifestyle in a healthy way to reduce that increased risk. For those that were diagnosed with colitis or Crohn's, inflammatory bowel disease, if they were also diagnosed with celiac disease, so those that had the wheat sensitivity and they had an inflammatory bowel disease, their standard mortality ratio, the risk that they were going to die earlier than people with inflammatory bowel disease without celiac, was 70.9 times more likely, 70-fold more likely to pass earlier in life, which means that all of our people with gut conditions just must be checked to see, do they have a sensitivity to wheat? Because if they do, and about 30% of the people with Crohn's do, somewhere between 20 to 35% of those with ulcerative colitis have a sensitivity to wheat. If they do, then we have to identify that, or their risk of dying earlier than someone with colitis or Crohn's is 70.9 fold, not percent, fold, which is 700% more likely to pass early. That's how important this topic is. So that when someone's diagnosed with an inflammatory bowel disease, they must be checked just to see, do they have a problem with wheat? Some will, some won't. About 1 or 3 out of 10, about 30% in general will have a problem with wheat. And in those people, wheat is the petrol on the fire, contributing to the inflammation. So we always just want to check.
Thank you, Dr. Tom. That's definitely a take home, that it's the fuel on the fire, like you said, and probably cutting out wheat is going to reduce that inflammation. So Ishima, I'm coming right to you, and we've seen this increasing trend in the incidence of IBD also over the past few years, not only in India, but all over the globe. And is there some kind of etiological factors that you feel are contributing to this increase, or is there something else you'd like to add related to this point, ma'am?
What I'd like to just say is that certainly what we call a typical westernized diet is contributing to this increase, and it is highly correlated with urban and rural differences. And I think, to my mind, that more than anything else, that is the biggest, what I call the change in the ecosystem, whether it's the Western diet, or whether the urban lifestyle or the urban ecosystem, that together has probably contributed. And maybe it's difficult to isolate one factor, but coming to inflammation through food, there is one clear fact that typically inflammation in our bodies, the chief contributor is food. All the other things, factors are there, which probably exacerbate the conditions. But clearly, food is one of the key things which is contributing. And we all know how foods have changed, how agricultural practices have changed, how much refined food we are taking, how many additives we're taking without knowing. So that's a part of our industrial food production, and the pesticides, of course, the use of high, the GM crops, high glyphosate consumption, when we are not at fault, it's just a part of the ecosystem. And I guess, the stress factors that all are adding to it. But the most profound factors are in our diet itself.
Sure. So very, very enlightening, ma'am. So I was reading only yesterday that it's not what you eat, but also how you eat. So there's a particular order also in which your starches are supposed to come at the end of the meal also. We'll discuss about that another time. But Dr. Raj, coming back to you. And my
Dr.
next
Raj,
question.
he's wanted to say something.
Yeah,
Yes,
I
please,
wanted to
please.
just add to the discussion.
Please, sir, please.
So looking at, one thing is very clear that even when we were medical students, Crohn's was supposedly unknown. I mean, we had case presentations, case reports of Crohn's in India. And over the last 30 years or so, the incidence of Crohn's has rapidly increased. And same thing has happened in many countries or many situations where the diet patterns have changed. So one thing is now very, very clearly established, that a fruit and vegetable based diet significantly decreases the chances of inflammatory bowel disease, and more meat-based diet, more high dairy, not average dairy, but high dairy-based diets. There have been animal studies where they've shown that high dairy intake causes dysbiosis and causes the bacterial flora to change in the gut, resulting in more linoleic acid formation and some other compounds, which then causes inflammation in the gut and can be a trigger. The problem with inflammatory bowel disease is that there are so many different triggers for different people that to make a blanket statement is not going to be possible. Unlike, say, in celiac disease, where we say gluten, yes, that's the culprit. Here, gluten will be one of the culprits, but there will be many other culprits which initiate this inflammatory response. So, but almost all the data points to one thing. If you have a high vegetable-based diet, lots of fruits and vegetables, your gut flora, the bacterial flora is healthier, your inflammatory bowel disease incidence is lower, your recovery from inflammatory bowel disease is lower, your requirement for biologicals and steroids lowers down. So if you have to have a general advice to people, then it has to be, number one, lots of fruits, vegetables in your diet, less processed food, as Ishi already pointed out, less additives, because many of the additives and preservatives also act as triggers. And then individually, the patients will have to identify that, for example, 30 years ago, we were saying no milk to any ulcerative colitis patient. And that turns out that was probably not the right advice, because although the incidence of lactose intolerance is 20 to 30% at times in IBD, and in those cases, it can be easily overcome with lactase supplement. There are some where milk is the trigger. And in those cases, stopping milk and casein hypersensitivity would definitely help improve the colitis. In others, like Dr. Tom pointed out, gluten. Now, gluten sensitivity, if you look at the large studies, there's a nurses study, a follow-up study where it took about over a 20-year period that quantified the amount of gluten taken, small amounts, moderate amounts, large amounts, followed these nurses over a period of almost 20 years. And then analyzed based on that, was there increase in incidence of inflammatory bowel disease? And they found there was not much difference between the low gluten consumers and the high gluten consumers. So the scientific data is always going to be a little difficult to interpret. Yet, when they looked at patients with inflammatory bowel disease, they found that the risk ratio of their developing celiac disease was 9 to 1. Risk ratio was 9, which means they were about 8 to 9 times more likely to have celiac. In patients with celiac, they were 3 to 4 times more likely to have inflammatory bowel disease. So there's obviously a lot of clear associations. We have to individually identify in each patient what may be the trigger. Some tests are IgE based, which are easy to do, food allergy tests, TTG antibody tests. Some we cannot measure. So what we tend to practice is that we have to avoid, we try a 3-month avoidance period, but one thing at a time. Avoid milk, see how you do. Okay, not much difference. Good nutritional content in the milk, we don't want to avoid milk. Avoid gluten for 3 months, 4 months. Significant improvement, stay off gluten. No change, not much change, then you're probably not in the group. And we do measure TTG antibodies, for example, now in all our inflammatory disease patients. We do measure wheat protein hypersensitivity tests and food allergy tests in all our IBD patients. So I think it has to be tailored very individually.
Great. So that's very, very interesting to know. So just wanted to touch up on the other etiological factors also. Obviously, environment is one thing and the diet that you eat. But apart from this, there's also genetic predisposition that I've been reading about. And there's also other factors like infections or autoimmune pathogenesis also is there. Could you tell us a little bit more about that?
Right. So I think infections has been something that has been a point of interest for the longest time, because especially Crohn's disease mimic tuberculosis. So the initial interest was that, are we dealing with just a different form of tuberculosis, atypical sort of non-pathogenic in acid-fast bacilli, which may be contributing. Most of that has fallen out of the window. The other interesting fact was that in low socioeconomic conditions where the infection rates were high in childhood, those patients didn't develop Crohn's disease or ulcerative colitis as much in later age, as opposed to more upper socioeconomic strata group, which had clean environments to begin with. So another interesting fact was that if the children are introduced very early to multiple antigens of bacteria, then they may somehow have a healthier gut and more strong gut microbiome. So as a result, they don't develop inflammatory processes later on. So we also know that infections trigger, so if a patient has ulcerative colitis, they get an infectious gastroenteritis from eating something outside. It triggers a sudden increase and they can have a flare in ulcerative colitis. So infection does play a significant part in the flare-ups, but there's no single bug or single gut organism that we can say is the reason for ulcerative colitis, inflammatory bowel disease. Also, many infections like Yersinia can mimic inflammatory bowel disease completely. So yes, so that is as far as the infection part is concerned.
So Dr. Tom, I think you...
Yeah, Dr. Tom.
Please continue, sir. So
I
Dr.
just
Tom,
wanted...
also please make your point and also touch up upon this particular test that usually physicians ask for. It's called an ASCA. And is it to differentiate between the two? Is it something related to infection? You could also explain about that, please.
Yeah, yes, thank you. I just want to emphasize what Dr. Raj just said, because people may have missed it, or because he gave us a number of very important points. And the one point that was so important was that children who had minor infections when they were very young, they had less risk of developing inflammatory bowel disease later in life. It's called the hygiene hypothesis, meaning when you live in a house or an environment where everything is sterile, everything is being cleaned every day with these chemicals that are now so common in our environment, in our homes. When you're cleaning and meticulous to be a good mother or a protective father, I don't want any dirt in this house. I don't want my child playing in the dirt. When we think that way as a parent, we put our children at risk, that our children have to be in the dirt once in a while. You know, it's like to exercise. If you want strong muscles, you have to exercise. You have to work the muscle. We have to work our immune system so that it gets stronger and stronger. And children that are not demanded upon inside their body to work the immune system have weaker, more vulnerable immune systems. That is a very important point that I want to make sure everyone takes home. Now, regarding your question about ASCA antibodies, the term means when your immune system is fighting a particular type of yeast. And it turns out that somewhere between 50 to 80% of patients diagnosed with Crohn's disease will have elevated antibodies to ASCA, which means that the amount of yeast in their intestines is too much. And the immune system is using its energy to fight that yeast. Now, we hear about the good bacteria in the gut, and it's critically important. You know, I've said many times, if there's only one thing you're going to do in life to be healthier, it's build a healthy, diverse microbiome. Nothing protects you more than that will. And that's the job of the Celiac Society of India. And they have very good educational programs and handouts to learn more of how to build a healthy, diverse microbiome. But when you do not have a healthy, diverse microbiome, sometimes some of the yeasts, some of the bacteria that are okay in small amounts, they just rear up and they become over dominant. And your immune system says, there's too much of those people around right now. We have to clean up a little bit. And you start making antibodies to fight the yeast in this example. And 50 to 80% of Crohn's patients have elevated antibodies fighting yeast. That automatically tells us we have to teach this patient how to build a more diverse, healthy microbiome. And it'll take 1 year to 2 years to do that once you understand the mechanisms of bringing in more good guys, feeding the good guys, and don't feed the bad guys so much. And that's what education, nutritional education, accomplishes.
Thank you, Dr. Tom. So just wanted to complete this topic just for the sake of completion. And Dr. Raj, could you tell us about some other modalities for diagnosis that we use in these IBD patients? We've all heard about the fecal calprotectin, the lactoferrin, also ANCAs. Sometimes doctors ask for that. And any other testing modalities that you would want to discuss on this forum today?
Right. So testing modalities, we sort of divide testing into what we call non-invasive biochemical testing, the radiological testing, and then the endoscopic testing, and eventually surgical sometimes required. So looking at the biochemical, the common thing we look at is the inflammatory parameters like C-reactive protein, blood counts, eosinophil counts, white cell count, and ESR. So those are the inflammatory parameters. Fecal calprotectin has been around now for the last, I think, 5 to 7 years primarily. It's a very useful parameter. It just tells you that it doesn't diagnose inflammatory bowel disease. What it does tell you, if there's inflammation or ulceration, then the inflammatory cells called neutrophils produce this particular substance called calprotectin. So if they are present in large numbers in the gut anywhere, then your calprotectin levels go up. So it's a good parameter to separate out IBS from IBD, because in inflammatory bowel, in IBS or irritable bowel syndrome, your calprotectin will be normal. In inflammatory bowel disease, when it is active, your calprotectin will be high. When it is inactive, your calprotectin will be normal. So we use it for two purposes: separate out IBS and IBD and say these patients need a colonoscopy because their calprotectin is high. These patients look like IBS. Now we know that calprotectin is also low, so we don't need to subject them to more testing. That is one. Second, we use it for in patients with known ulcerative colitis, inflammatory bowel disease, or Crohn's, and say we started treatment, the calprotectin was 2000. Now after treatment, the calprotectin has come down to 100. And next time they start getting some symptoms, irritable bowel syndrome, overlaps, functional symptoms, let's see the calprotectin rather than repeating a colonoscopy each time. Calprotectin remains low, we are more comfortable. Calprotectin has gone up high again, we may need to adjust their medication or investigate. So that's the role of calprotectin. Then we come to radiological, which is CT scan primarily, which is the main modality we use. And that is to see if the small bowel involvement is there or not. And Crohn's has multiple complications: stricturing disease, narrowing, stricture formations, abscess formations. So we mainly look for all those things, lymphadenopathy. In India, especially, we use this a lot to separate it out from tuberculosis because they are like brothers and sisters. They look so similar, even on radiology and otherwise. So we have to use CT scans. We use some other imaging modalities, sometimes CT enterography, MR enterography, which are all geared towards seeing what's structurally happening. And then we use colonoscopy, sometimes small bowel capsule endoscopy to look at the small intestine, and then colonoscopy, enteroscopy to take biopsies, and then look under the microscope. And diagnosis and management of inflammatory bowel disease depends on a multitude of these things put together. So there is no single test that will say, this is Crohn's, this is not Crohn's, or this is ulcerative colitis, this is not ulcerative colitis. You'll have to look at these, put a jigsaw puzzle together. And once we have the jigsaw puzzle complete, then we say, okay, now how do we treat? And there are multiple treatment modalities, which we go again in a step up manner or step down manner, depending on the severity of disease.
Dr. Raj, that's very well explained. And I meet patients on a daily basis when they ask me, is this test a yes or a no? And for me to tell them that this is not black and white, this is only a gray zone. It needs to be clinically correlated. You put it very, very well.
One of the first things one of my professors right in first year had said, in medicine, Never say never and never say ever. So there's no test which is 100% accurate. There's no test which is 100% positive predictive or negative predictive.
That's right. Even my father says this all the time, that you're not treating the report, you're treating the patient. So it's always the correlation that matters. So Mrs. Khosla, coming to you, my apologies, I couldn't come back to you before this. But there is a huge role, ma'am, obviously, that diet plays in controlling the flare-ups of IBD. Obviously, therapy and medications is extremely important, but also that we see that the exacerbations that you have are directly proportional to what kind of diet you're taking. Also, I've read and heard that there is a huge role of integrative medicine, maybe other kind of therapies like yoga or anything else that you can tell us about. And for the audience watching today, also any pearls of wisdom from your side?
Yes, I will certainly answer your question, but I was very tempted to add to what has been said by Dr. Tom and by Dr. Raj about tests and about gluten. So that maybe a food intolerance test would also be of value to the protocol that is being followed. And that the TTG, which is the tissue transglutaminase antibodies, or the endomycelial antibodies to rule out celiac disease, also need interpretation, just like the food intolerance and the food allergy tests. And I don't think food allergy test really has a role to play, a big role to play compared to the IgGs. But interpretation of a negative TTG, and I really request Dr. Tom to highlight while so many people seem to be having a negative TTG value, and we know that the problem exists, the classical picture is there, and yet we allow them to just be untreated. So what would you like to say about a negative TTG? And also another point before I move on would be talking about wheat in perspective to gluten and the other parts of wheat, which is the non-protein parts, which are the FODMAP category, which again I'd like Dr. Tom to elaborate.
It's a thank you. It's a very important question. The TTG has been accepted as the diagnostic test, blood test for celiac disease. There is a big problem with that acceptance. And there is no argument that the studies are very clear. If you have celiac disease, the TTG test will come back positive 97 to 100% of the time. The studies are very clear. The problem is the studies that in order to prove that the tests were accurate, they got blood that was in storage of people who had celiac disease. And they looked at the blood and they'd say, yeah, look, everyone or 97% of the people have this elevated TTG. This is a good test to identify. But the blood in storage of people with celiac disease are people who were diagnosed with celiac disease. Okay. But the people who are diagnosed with celiac disease are only those that have what's called total villus atrophy, meaning that their intestines are at the end stage of celiac disease, where their microvilli have worn down completely. If they were partial villus atrophy, meaning that they're on the way to complete loss of intestinal function, then the accuracy of TTG is 27 to 32%. And there are a number of studies that say this. So our doctors cannot use TTG as the test to say it's okay to eat wheat because you don't have celiac disease. They may very well have a problem with wheat and they just haven't had the ends progressed to the end stage damage yet. But the TTG is very, very accurate for people that have celiac disease, which is total villus atrophy. And it takes about 7 years. And some of the studies are trying to identify how long when they follow the genes that activate the inflammation that wears down the inside of the intestines, about 7 years after the genes are activated. So that's a very important point that most of our doctors don't know. And when I talk about this on stage, you see the doctors, they start to cross their arms. What do you mean TTGs? I've read the studies. Yes, of course, and they're very accurate studies, but we have to remember who were the group that they were testing. And they were only testing the group that was at the end stage of celiac disease. So TTG is a very good test, but it is not a test to determine a sensitivity to wheat. And to Ishi's comments about other components of wheat. Some studies are telling us that there's a component called amylase trypsin inhibitors in wheat, ATIs. And this is the part of the plant that is Mother Nature's protection against bugs. If the bugs eat the plant, the ATIs in the plant, they taste bad, and so the bugs usually stop eating. But if they eat it, the ATIs will cause severe leaky gut and the bug dies. So they've learned not to eat the plant. That's Mother Nature's protection. Well, those ATIs are in the wheat that we eat. And the ATIs are more sensitive. The immune system fights the ATIs more often than it fights the gluten in wheat. So if you're only checking for the gluten in wheat, you might miss the problem because the patient may not have a problem with the glutens. We know the most common gluten test is alpha-gliadin, which is one of the gluten proteins, but 50% of celiacs don't have an immune reaction to alpha-gliadin. And so if your doctor is only doing the alpha-gliadin test and so, well, we'll check you for wheat, and the laboratory does alpha-gliadin, which is a very good test, but you might miss 50% of the people that actually have the problem. So that's the world that we're in. And that's why it's so wonderful that we have Dr. Dang as our host here, who runs one of the more well-known labs in India to help bring us more up to date with our testing.
Absolutely. So Dr. Tom, my question was to you. So TTG, I understand, and anti-endomysial and anti-DGP antibodies, the ones that you are referring to. And also there's a huge amount of false negatives in this, because if anyone is on a gluten-free diet, that people these days, usually it's a fad also that people do, and they're on a gluten-free diet and then they get these tests done, then the chances of a false negative are also quite high. And so that is always a disclaimer that we try to give out before testing, that there should be small amounts of meat in case, there should be small amounts of wheat in case we need an accurate result. Great. So coming back to you, Mrs. Khosla, and also I see Mr. Chandwani has joined. And if you allow me, ma'am, I'll just quickly take him in and ask a couple of questions. Hi, Mr. Chandwani, are we audible to you?
Mr. Chandwani, can you please unmute your speakers, please?
So
I'm doing it.
Yeah, hi, Mr. Chandwani.
Is it okay now?
Yes, thank you so much. Yeah.
Yeah.
Hi, Mr. Chandwani. Greetings to you, and it's great to have you in today's discussion. Am I audible?
Yeah. I'm
his camera
audible.
is,
This you are audible.
video is off.
Great. So, Mr. Chandwani, like I said, it's really good to have you here, and looking forward to listening
Same
to
here.
your experience. And I believe that you've known about your condition since more than 10 years now. And how has that journey been? And
I had the first bout in 2010 of ulcerative colitis, and then after 22 and second bout in 2016, and then in 2016 I consulted Ms. Ishi Khosla, and she decided me to put on gluten-free diet, lactose-free diet, dairy-free diet, and since then I'm on that gluten-free and lactose-free diet. And fortunately, unless I cheat on that, I mean, I sometimes out of my contention, I eat some wheat portion or some milk product, then I feel have a problem. Otherwise, I am facing no problem. I am out of medicine. Earlier, I was taking that Mizagol OD twice to morning, twice to evening. That was reduced to 1, then further reduced to 0. And now I am totally medical free, medicine free. And I'm taking
Great.
all the precautions. I'm doing yoga, and then I'm having all the precautions of not having any gluten or any lactose. So I'm
Great.
really grateful to Ms. Ishi and the team. I keep on listening to all the team members, and I really feel encouraged to know that this diet plays a very important role in our treatment.
Absolutely. Absolutely. Thank you, Mr. Chandwani, so much for that. And like what Dr. Tom was saying earlier, IBD is like the fire, but then the diet is the fuel to the fire. And if you are following that diet correctly, and obviously you are testimony to this also, that Mrs. Khosla's guidance about which foods to be avoided. If you were following that and very compliant with it, obviously you saw the results. Thank you so much for joining, Mr. Chandwani, and super grateful that you took the time to share your experience with us and the audience. And Mrs. Khosla, just to conclude this integrated therapy to control and monitor your IBD symptoms, is there something else apart from your diet also, like yoga and other things that Mr. Chandwani was mentioning? Maybe a quick comment on that.
Oh, yes. Since we're talking about the gut microbiome, the bugs don't like stress and toxic environments and toxic emotions. So any strategy or tool which helps to relax and calm your environment and calm your inner system is going to be of value. And that's what yoga is all about. And regular physical activity also is important, but too much or excessive can be counterproductive. That is clear. Also, to just highlight what Mr. Chandwani was talking about, that whenever he took the triggered foods, which were what we eliminated, he always relapsed. And there was a time when he was not symptomatic, but he started dairy in small amounts, and he probably did not have obvious symptoms, and he became bolder and more took more risks with his diet and started having it regularly on a daily basis. And that's when he had his flare up again, and all the bleeding and everything started. He had to be put back on medication, and bit by bit we've healed him back. And so he's on probably almost nothing, or very small dose or nothing these days. More than anything else, apart from the elimination we're talking about, it's very important to add the right elements as well. And since your question on diet remain unanswered, I'll take this opportunity to highlight some key parts of a diet, particularly on a long-term basis. In the acute phase, of course, elimination of the trigger foods is important, and low fiber diet is important. And having healthy fats is also important, the right kind of fats, which are anti-inflammatory. And I think in all our webinars, we've been talking a lot about these omega-3 fats, which have been found to be useful, the fish fats, also several, plant versions of these fats like chia seeds, etc., are good. But also the nutrients, the micronutrients, because these people are really suffering from malnutrition. And, besides all the dysbiosis, and maybe because of the dysbiosis and the state of the gut, they are usually very low on iron or low hemoglobins. They have low vitamin B12, vitamin D, calcium, magnesium, folic acid. So all of these, and magnesium is very, very important actually, because we tend to ignore it in favor of only calcium. But we need to up these and make sure that they are really brought back to optimum levels through supplements. And needless to say, since we are talking about the microbiome and the dysbiosis, the importance of probiotics and prebiotics, which is really very, very important. And by and large, once the patient's symptoms are under control, more or less, it's a normal diet. They can have normal proteins and easy to digest food, of course. And we haven't still spoken about FODMAPs, which is the certain kinds of sugars in our foods, which can also be adding as trigger foods to, like fruits, etc. So over to you, Tom, to talk about that.
Oh, thank you. I just want to be clear that we are not saying it's okay to cheat once in a while.
Yes.
Because by the time you feel symptoms, the fire in your intestines has been going on and going on. You don't feel symptoms right away when you take in something. Usually you don't feel symptoms right away, especially when you're recovering and you're symptom free. And then you take something in, and some doctors call it cheat days. It's okay to have a cheat day. No, it's not, because the fire continues right away and it's going to cause damage. And it's only after you cross a particular threshold of damage that you start feeling the symptoms. You don't feel the symptoms right away. So cheat days are never okay. And what I've said for years, you cannot be a little pregnant. You cannot have a little wheat if you have a problem with wheat or dairy, or it doesn't matter what it is. So I just want to make sure we're clear on that. We are not advocating have a little bit once in a while, as long as you feel fine.
And I would take this opportunity again to come back on this and say that a lot of people, even in eateries, say, oh, are you celiac? Or you're just not, just avoiding it. So we will be vigilant if you're celiac, and if you're not, we will be a little easy. Because that's the message which goes across, that, you can have it on and off just because you're not celiac. So I think that's really important to highlight. And of course, we also need to add some anti-inflammatory herbs, and which are, so integral to the Ayurvedic concept. You talked about the integrated medicine, the holistic approach. So in India, we have so many herbs. We have ashwagandha, we have giloy, we have Boswellia, we have curcumin, that's the king these days, and so many other, digestive herbs which can support the system and build the architecture and reduce the inflammation.
Dr. Raj, go ahead. Please unmute yourself.
You're on mute, doctor. You're on mute.
Yeah, sorry. So I was just saying very important points brought out. There are just a couple of comments and some what I would say, I won't say concerns, but points to remember. So number one, I think stress plays a huge role, as she pointed out. So anything that de-stresses the body. And most of the time I tell my patients, we are treating you as a human being. We are not treating one disease. And almost all the advice that we are giving applies to many diseases. So when we say have more fruits, have more vegetable-based diet, avoid processed food, avoid refined foods, it's helping your liver, it's helping your heart, it's decreasing your cholesterol, it's decreasing your lipids, it's controlling your sugars, it's decreasing fatty liver disease, it's decreasing heart attack risk. So I call it my Ramban, and I call it my jungle diet. God created human beings as apes. If we eat what God created us to eat, we are in general healthier than what man created for himself, whether it is alcohol or tobacco or burgers or pizzas or fried pakoras, whatever the more we modify the food, the worse it becomes in terms of health. The second thing I wanted to just a word of caution about Ayurvedic drugs, because there is a tendency to believe that they're completely harmless, and many times you actually end up with significant side effects. During the period of COVID, when people were overusing these drugs, we have had many patients with severe liver disease, to the extent the bilirubin going up to 14, 7, and we investigated it thoroughly, including liver biopsy. And when the history came out, they were doing a lot of giloy and ashwagandha and everything else together, or using mega dosages, or using for prolonged periods. So we don't know enough about the chemical compositions of these drugs. So one has to be a little careful about how much, when, and how to monitor them. So if we are using those medicines, we definitely need to monitor the kidney function tests and liver function tests fairly frequently, because they are the two organs which eliminate all the drugs. Many times we get drug-induced liver injury, drug-induced kidney injury from many of the drugs. I'm not saying just Ayurvedic, the same thing happens with allopathic drugs. We monitor that. But when we put them on Ayurvedic drugs, they're not being monitored. So many of them will have side effects. And curcumin is a very good example that, curcumin in normal doses, slightly upper dosage is okay. But curcumin in high doses actually is metabolized by the C450 system, and there can be drug interactions with that. So we have had at least 2 or 3 patients where the only thing they were using was very high doses of haldi, and they had been on chemotherapeutic agents for cancer, or they had been on tamoxifen, and they had liver toxicity. So I think put this all together basically before we advise patients what to do and what not to do. but a huge role for yoga definitely, and for many of the alternative medicines that we can use safely.
Great.
What I
Thank
just
you.
like to add is that's an absolutely brilliant point, and that everything should, whatever we've talked about, whether it's the Ayurveda or the supplements, needs to be done under supervision of a qualified person. I think that's the number one message. Everything can be toxic and everything can be beneficial depending on how you're taking it and who's prescribing it. So.
Great. So I have another question, but I'm not sure who to direct it to. So anyone who can help me resolve this dilemma. So I do get patients who have a low hemoglobin and are in the moderately to severe anemic category. Now, these IBD patients with a low hemoglobin, how do we give them iron supplementation? Because that also interferes with the gut flora, etc. So could you tell us a little bit more about how to handle these patients?
Can I jump in for that?
Please.
So number one, iron deficiency is a consequence of invariably in IBD patients of two things. One is microscopic blood loss. So if you can identify active disease, ulceration, whatever else, you obviously try to increase the level of treatment. So if they are on only 5-ASA, they may need a short course of steroids. They may require biologicals, because iron deficiency is one of the manifestations of ulceration and inflammation. So number one, that. To supplement, mostly iron doesn't cause that much change in the gut microbiome. It does give side effects. So you can have constipation at times. Many people will have gastric side effects and may not tolerate the oral iron supplementation. So these days, IV iron infusions has become very safe, which used to be a point of concern in the past, where we used to have at least a splattering of reactions. But with the newer formulations of iron, we don't get that much, hardly get any IV iron infusion related reactions. So that's a fairly easy and safe way to do that. It requires just a hospital visit for maybe a couple of hours and can be done as a daycare case. But I think it's important to know why they are deficient. Second thing is that many of the IBD patients are more prone to develop cancers longer they have had ulcerative colitis or Crohn's, more the incidence of cancers. And one of the manifestations of that can also be iron deficiency, weight loss, drop in hemoglobin. So one has to screen them, at relevant intervals, depending on the case, to make sure that they're not developing polyps and cancers in the colon, for example, which will make them iron deficient.
Sure. Please, Dr. Tom.
There are a significant number of people who have had anemia for years, and they try taking iron supplements and they don't work, that they still have anemia when they go back to their doctor to be tested again. And many of our listeners today will have had that experience where they have a family member or a friend who just doesn't have the energy because they're anemic and they've been anemic for a long time and the supplements don't work. When they do an infusion, as Dr. Raj is talking about, they feel better. Their iron levels go up. That is a classic example of someone that has a problem in their gut. There's something going on in their gut and they're not absorbing the iron from their food or from the supplements they're taking. So for those that have chronic anemia and the supplements don't work, you must check your gut to see what's happening in the gut.
The example I give patients is there's like a water tank. Now you can fill the water tank and you say, oh yeah, now our tank is full. But if you don't check where the water was leaking from, then it is just a temporary fix. It's really not fixing the actual problem. So gut is the commonest source of microscopic blood loss. Number one, is the commonest source for poor absorption of iron. So on both senses, we got to test the gut completely.
Great. So I think I have time for another question. I think Dr. Tom, what you were saying yesterday, I think we'll need a full weekend if we need to discuss all the questions I had prepared. But just a quick question, and I've also seen that there is a lot of patients who suffer from several psychological disorders who have IBD, and obviously this is a very significant lifestyle condition also to have that disturbs your routine and your daily activities. But otherwise, is there something that we should understand more about this connection between the gut and the brain?
That is a very important question. And the answer is, it was Professor Michael Gershon from Princeton University that wrote the book for the general public in 1999, over 20 years ago, called The Second Brain. And he showed us in that book that for every one message from the brain going down, giving instructions to the gut of what to do, there are 9 messages from the gut going up, telling the brain what to do. The ratio is 9 to 1. The hormones in your brain called neurotransmitters, the balance of those hormones is completely at cause when you have depression or anxiety or schizophrenia or bipolar disorder. Any of the brain dysfunction diseases have imbalances in the brain. I call them they're not hormones, but for people to understand, the neurotransmitters, there's an imbalance there. And that imbalance is completely controlled by the messages from the gut. 36% of all the small molecules in your bloodstream are the exhaust, the metabolites of the bacteria in your gut. So over 1/3 of everything in your bloodstream are these metabolites. And what are they? They're the messengers from the bacteria in your gut that are going out to tell the brain how many neurotransmitters to make and which ones. They're telling the heart what the heart rate should be. That are telling the liver, detox this, break. So these messengers from your environment in the gut that we call the microbiome are critically important for healthy brain function, healthy liver function, healthy heart function. The list goes on as more and more studies come out. So once again, if there's only one thing you're going to do to be healthier, it's build a healthy, diverse microbiome. And the only way to do that is to get education, like being here today, of course, and the Celiac Society of India, and learn a little bit more every week of what are the foods that I can eat that help to build a healthy microbiome, and what are the foods that contribute to a not healthy microbiome. It's a critically important way of thinking for our patients to be healthier long-term.
Great, Dr. Tom. So I think we don't have many minutes left, but if there are any kind of questions from the audience, Arjun, could you help us with those questions? And
I think our panelists have covered the subject extensively. I have not really got any questions from the audience right now, but I'm sure if they do come up with any questions, we'll be happy to address them offline as well.
Great. So I think we are in a position to conclude, but like we do every time, and if everyone allows me, just a closing comment or just a take home, the most important with someone who has IBD, what to do in their daily life or their routine. Just like a 30-second closing, maybe from our 3 esteemed panelists. Mrs. Khosla, starting with you, please.
I would simply say these are action points that clearly know your trigger foods and avoid them scrupulously. Also, it's not only about what you eat, but it's also how you eat, when you eat, and how much you eat. So watch your parameters, watch your BMI, watch your waist, and all the foods that you eat to maintain your statistics, and also monitor your blood work. That means keep track of your markers and be in touch with your treating physicians, and really make this a way of life. And like Dr. Vivek Raj just said, if you do that, you're not only helping your gut, but your entire body in every cell, head to toe, inside out, and from your mind to your physical body. So
great, thank you.
Simple takeaways there.
Thank you. Vivek sir, anything from your side for the audience to take home and remember from today?
So I think for the IBD patients, very important, that's a lifelong disease and it has to be monitored. And even when you are well, so don't visit the doctor only when you are unwell. It is when you are well that a lot of the advice will sink in and a lot of things will be preventive. When you're unwell, then you will just be treated for the disease. But when you're well, that's when a lot of the preventive aspects will come in. So stay in constant follow-up, whatever the duration may be with your doctors. Also, dietary advice, as Ishi has already said, and my dietary advice, and my buzzword these days, jungle diet. So stick to a lot of high fiber, lots of fruits, vegetables, natural foods, avoid processed foods, definitely avoid alcohol and smoking. something that decreases the risk of cancers everywhere and decreases the risk of pancreatitis, inflammatory bowel disease, multiple things. Be aware of specific, don't be a complete exclusion diet, because a lot of patients come in. My neighbor told me to stop eating this. My doctor, I read on Google, Dr. Google actually that is the biggest problem these days. So I did my research and I have done this and I stopped this, and this. So if you're excluding too many things from the diet, then you are going to have nutritional deficiencies, which will be counterproductive. So one has to do this in a discussion with your physician as to what to avoid, how long to avoid, how to monitor your diet, what to build up, what to build down. As Ishi rightly pointed out, micronutrient deficiencies, vitamin deficiencies are extremely common. We got to be very, very aware of how to build that up, because that builds up your immunity, that builds up your, it decreases the risk of your heart attacks as well. You know, atherosclerosis related to vitamin D deficiency, inflammatory bowel disease related to vitamin D deficiency, many different things.
Thank you, sir. And Dr. Tom, I always like coming to you the last so that we can finish the session also with something very interesting. And is there something that you would like to share with us?
Oh, thank you. I fully agree with what Dr. Raj has just said. Stay in communication with your doctor if you've been diagnosed with an inflammatory bowel disease. But not all doctors are educated equally. So the doctor that identifies your disease and helps to keep you stable may not be the doctor who's been trained and understands about dietary influences. So you have to ask a couple of questions with respect to your doctor, but you have to kind of see, what do they know? You know, what training do they have? Or can they refer you to a dietitian? In other words, you have to make sure the experts that you're using to trust are educated in the field that you want more information. And one of the ways to help with that is go to the Celiac Society of India's website and start reading, and just 1 hour a week. If you allocate 1 hour a week, you tell your family every Tuesday night after dinner, every Sunday after services, whenever it is, but at this time, don't bother me. I'm going to learn more of how we as a family can be healthier. And now you're going to learn a little bit more 1 week about where some of the inflammation comes from. And then next week, you're going to learn something new. And then next week, you're going to learn something new. In 6 months, you've got this. You've really got it. So be kind to yourself. Don't expect to understand how to change your lifestyle in 1 day. And you will feel overwhelmed by all of the information, but just put your toe in the water a little bit at a time, 1 hour a week. And then next week, you'll put your ankle in the water 1 hour a week. You know, that you just learn a little bit more. And in 6 months, you've really got this.
Great. Thank you, Dr. Tom. And obviously, education awareness is critical, and we couldn't agree with you more. And thank you, everyone. Thank you so much. And it's been enlightening as always. And I've been taking mental notes, and I think we had hundreds of attendees in today's session. So I think, and I hope it was productive for everybody. And if there are any attendees who have a question, then Arjun, please do share the email ID or the communication link through which they can reach out to us, and we can resolve their queries as well. And thank you, Mrs. Khosla and Dr. Raj and Dr. Tom O'Brien. Pleasure and a privilege, like always. Thank you.
And thank you, Dr. Arjun Dang, for moderating this lovely session. Thank you all. Have a great day and a good weekend ahead. We'll see you all next month again with another of our webinars related to wheat-related disorders. Thank you.
Thank you. Bye-bye.